Hi, I'm Jared Gardner, and I'm here today with my dermatopathology fellow, Ed Fulton. And Ed has selected an interesting topic and some nice cases for us today. We're going to talk about an entity called Hobnail Hemangioma. It's also referred to as by the name Targetoid Hemosiderotic Hemangioma because clinically sometimes it has a ring or targetoid shape that's kind of a brown color because of hemosiderin deposition. And these are interesting lesions because of, well, for a few reasons. For one, they have hobnailed cells. Now, hobnail is a term that gets thrown around a lot in pathology in general, but particularly in regards to vascular lesions. Hobnails were, my understanding, a kind of a bulging-looking nail that was used in old-timey, I think in old-timey shoes, and also you can still see them sometimes used on leather furniture. Anyway, you can Google hobnail and find a bunch of pictures to see what hobnails actually were. But now in pathology, that term is stuck around, and it's been used for a variety of different things, which has caused, I think, a lot of confusion for people. And there are a handful of different entities that can have, in vascular lesions, that can have hobnailed cells. So one of them is the Hobnail Hemangioma. So let me find where some good hobnails are here. Got to look around for them. Here we go. See right here, let's get in on high power. You can see that the endothelial cells kind of bulge into the lumen of the vessel, and they don't have much cytoplasm around them. They almost look like little naked nuclei that are kind of pushed in and sitting in on the very surface of the very edge of the vessel, bulging into the lumen. So that right there, those are kind of hobnail endothelial cells. And I suppose hobnail is kind of in the eye of the beholder. Here's a few other ones. And sometimes people have used the term for different lesions, they'll call them like matchstick-like. They look like the little head of a match with a little stick underneath of the cytoplasm holding on there. So again, you can see these in a variety of things. So just because something has hobnail cells does not mean it's a hobnail hemangioma. All right, so like for many things in dermatopathology, I think the easiest way is to actually go back out to low power here and start at the very lowest power. So Hobnail Hemangioma has a kind of a unique low power appearance. At the surface, in the superficial dermis, you have dilated vascular spaces, big open channels, all right? When you go closer, you can see that they have that hobnail endothelial lining. Here's another one. See, look, this kind of matchstick looking cell right here. Right there looks a little bit like a matchstick. Those are some beautiful little hobnails right there sticking in. And they don't have atypia or anything like that. They're just little hobnailed endothelial cells, okay? So you've got the dilated channels up top, but then as you go deeper, what happens is those channels begin to compress and they turn into these kind of thinner, more compressed channels. And as you go deeper and deeper down into the dermis, the channels become quite compressed and almost can start to look slit-like. Now, if you've been studying dermatopathology for a while, you probably recognize that the term slit-like vascular channel is a buzzword for Kaposi sarcoma. And the important thing with this entity is not to mistake it for Kaposi sarcoma. We'll have to do a different video about Kaposi because it's a whole topic unto itself. And but anyway, these compressed channels are a little different than the channels in Kaposi sarcoma, but it's always a good differential to keep in mind, okay? So you'll have the dilated channels up top with hobnailed cells. Down deeper, you'll get these compressed, almost slit-like kind of channels. And then most cases will have this, hemosiderin deposition. So these little vascular channels leak and they release blood into the dermis, and then that blood breaks down and makes this golden colored kind of hemosiderin here. There you can see some more hemosiderin right there. And that hemosiderin is what gives this a unique appearance clinically. Clinically, when I see Targetoid Hemosiderotic Hemangioma or Hobnail Hemangioma, whichever name you like, when I see those biopsied by dermatologists, I would say more times than not, they suspect that it's going to be a pigmented melanocytic lesion more than a vascular lesion. And I think that that's because the abundant hemosiderin in some cases really makes the lesion look very dark clinically. And only sometimes does it have the ring or targetoid shape. I feel like oftentimes it just looks like a solitary pigmented lesion, and it'll get sent in to me with a biopsy saying rule out atypical nevus or rule out melanoma, something like that. All right, so those are the three main features. Now, like I said, that you should make sure that you don't mistake Kaposi, because Kaposi also tends to have hemorrhage. Kaposi sarcoma has hemorrhage, and it has hemosiderin deposition, and it will also have inflammation. In this case, has a little bit of inflammation. So if you see a lot of inflammation, particularly plasma cells, or if the patient has HIV, or the lesion is on an old person on the lower extremity, kind of the scenarios where you would get Kaposi sarcoma, think about Kaposi, and if you have any concern, you can do an HHV8, human herpes virus 8 stain, which will stain positive in almost essentially every case of Kaposi sarcoma, and will be negative always in Hobnail hemangioma. So those are the features of a Hobnail hemangioma. Let me show you a couple other examples, and then we'll talk about a few other things that are in the differential diagnosis. Here's another really beautiful example. Well, once I turn the light down appropriately. You can see here that in the superficial aspect of this lesion, there are dilated vascular channels. Again, you can see that they've got blood floating around in the spaces. And then even from low power, as you look down, you can see that the channels are still there, but they're starting to get smaller and more compressed, and even kind of slit-like in areas as you go deeper into the dermis. Let's go in for a closer look. So here in the center of this vascular channel, you have actually like a papillary structure. It's kind of a funny cut showing kind of a tuft of endothelial cells. Now there's other entity called Dabska tumor, which is super rare, but also has little tufts like this, but it's usually much larger, much deeper, more infiltrative, and you would have kind of structures like this, but way deep down in the dermis or the soft tissue, okay? So Dabska tumor is very rare, but it's a thing that you can keep in mind. So again, we've got the dilated channels that are right here in the papillary dermis. They've got blood floating in them. They have some hobnailed lining, like right here. Those are hobnailed cells. But look at most of the endothelial cells are actually flattened and not hobnailed. So don't expect that every single endothelial cell needs to be hobnailed for it to be a Hobnail hemangioma or Targetoid Hemosiderotic Hemangioma, if you like. Okay, and then again, look, as we go deeper down, you can see there's some more vessels. This one's packed full of blood. This one's compressed. There's hemosiderin right here. Let's see if you can see it on the screen. There's hemosiderin deposition, golden and brown in some histiocytes and floating around here in the dermis. Here's more of the vascular channels that you can see are still well formed. They're lined by endothelial cells. That's why I don't like the word slit-like for these, because it sounds like you're saying it's Kaposi sarcoma. These are just really compressed. If you took a kind of one of those vascular spaces you saw at the top of the lesion and squished it on both sides, it would make this little squished, compressed channel. Still well formed, still lined by a single layer of endothelial cells, but kind of thin and long. And that's the features again that you'll see. Those are the features you'll see in Hobnail hemangioma. So those are really nice examples. And they often occur on the extremities of young adults. I've seen them in children also. I think here's one more. This one actually has a lot of the dilated channels up top. But again, as you go with increasing depth, you again begin to see compressed, thinner little channels as you go down deep. And if you look around, usually you'll find hemosiderin. I occasionally see ones that don't have hemosiderin, or that you have to really hunt around for hemosiderin. So again, if overall it looks like a Hobnail hemangioma, but it's lacking the hemosiderin or something like that, if I still think that's the best fit and I've made sure I'm not missing Kaposi sarcoma or something else, then I feel comfortable making the diagnosis. Kaposi sarcoma usually, not always, but usually lacks these big dilated spaces at the top. Now, I've seen some examples, rare examples of Kaposi that did have channels like this. I've also seen areas in angiosarcoma that had dilated channels like this. Angiosarcoma usually is going to have a lot more cytologic atypia, but I've seen exceptions where angiosarc had a very well-differentiated, bland appearance in some aspects of the lesion. So I'd say the one word of caution there is, if you're on the sun-damaged head and neck of an older person and you see big dilated spaces with some kind of hobnailed cells, stop and think about maybe could it be angiosarcoma, especially if you don't see the whole lesion. Get the clinical information. And I've got a whole video about vascular tumors, especially focusing on angiosarcomas and the malignant and intermediate vascular tumors. And I'll put a link up here at the top corner of the video so you can click and go see that if you're interested in more ways to make sure that you don't miss angiosarcoma, because angiosarcoma definitely can have hobnailed cells as well. So you don't want to miss an angiosarcoma. All right. But for small lesion on the extremity of a young adult, no atypia, and it looks like that, you're probably dealing with Hobnail Hemangioma. And I think I've got one more of them to show you here. So again, with the dilated channels up top, and going down deeper, you may not be able to see the channels from here, but you can see that the dermis is busier. It has more cellularity, more structures there than normal. You can see already that there's hemorrhage over here. And the reason there's hemorrhage is because we've got these compressed vessels and they're leaking blood. And looking around, we'll find some hemosiderin deposition, okay? So I think the theory that I've heard is that these might actually represent a kind of a traumatized or damaged hemangioma or lymph angioma or vascular malformation, and that's part of why they have this kind of funny appearance. I'm not sure if it's fully known yet or not. There may be literature out there that I just am not yet aware of. I have still not read every paper in the literature, and I probably won't in my entire career. So we learn new things every day in pathology. So that is Hobnail Hemangioma or Targetoid Hemosiderotic Hemangioma. Now there's a few things that you should also keep in the differential, other benign things that can look like this. So let me show you some of those. I think this is the one that causes people more angst and confusion than most others. Let's see if I can get it into focus here. And this entity is called a microvenular hemangioma, okay? And if you look, you can see that we don't have those dilated spaces up top like we had in the Hobnail hemangioma. All we have are these compressed, elongated vessels that are kind of snaking or intercalating between the reticular dermal collagen bundles. So you can see them kind of weaving back and forth. And the lesion has these elongated vessels, and it's not circumscribed at all. It looks kind of like it's almost infiltrative. And so that, I think, is one of the reasons that this kind of worries people. Just like how the base of the Hobnail hemangioma had these compressed, almost, quote, slit-like vessels. Well, that's the same kind of vessel that you see here in a microvenular hemangioma. But if you look closely, you can see again that these vessels are actually well formed. They have one layer of bland, not atypical, but bland endothelial cells. And they usually, especially if you do an actin stain, you can see a layer of pericytes, which are modified smooth muscle that surround each little vascular channel. Usually you'll find a layer of pericytes around each vessel. And that's a feature that you're not going to see in the invasive vascular channels of Kaposi sarcoma. And again, angiosarcoma would have usually much more atypia, and it would not just have these little well-formed vessels, but it would actually have anastomosing branching vessels invading deep into the dermis. So it would usually look quite different than this. All right, but I did an interview for the American Society of Dermatopathology a couple of years ago of Omar Sangüesa, who's a great dermatopathologist who's done a lot of work with vascular lesions. And a story that he told me that I thought was really interesting is that he thinks a lot of these different hemangioma subtypes, they're all benign. And you might, learning pathology today, you might say, why do we have to have all these different names, and why do we have to split and divide these hemangiomas into different categories? And his explanation was that some of these at least arose during the AIDS epidemic in the late 80s, early 90s, before there was antiretroviral therapy. Diagnosing Kaposi sarcoma was basically giving someone an HIV diagnosis and essentially a death sentence. That meant that before there was drugs available for HIV, excuse me, most people that got HIV died from AIDS. And so it was a huge deal to diagnose in a young person Kaposi sarcoma. And nowadays we see that we treat people for HIV, and HIV is, for many people, fortunately, becoming more of a kind of long, chronic illness that we can prolong for a long time with treatment. But in those days before antiretroviral therapy, it was a terrifying thing to give someone HIV, even more so than it is today. And he said that the reason that all these different subtypes may have been discovered were that everyone was trying to make sure that they weren't mistaking some of these things for Kaposi sarcoma. And back then, there was no immunostain for HHV8. That wasn't discovered until later. And so now it's easy. If you have any doubt, you can just do an HHV8 stain. If it's negative, then you're good. It's almost certainly, I've seen extremely rare exceptions where the HHV8 failed on a Kaposi sarcoma, but like one time, I think, ever. So now we have easy tools to be able to figure out if something might actually be Kaposi. But these thin channels without the dilated vessels over top, that's a microvenular hemangioma. Let me show you some other examples of that. And I'll put the link to that interview of Omar Sangueza up in the up at the top of the video there, so that you can click on it and watch if you're curious. All right, here's another really good example. This one looks a little different, and in fact, I think this is a little bit more classic for microvenular hemangioma. Here's a punch biopsy, and you can see that the dermis has a lot of stuff in it, right? It's not a normal dermis, it's more blue, not as pink. There are a lot of extra cells, and you can tell even from low power that the cells are kind of interweaving between the collagen bundles. So the normal dermal collagen is still in place. It's not been pushed out of the way or removed. All this cellularity is kind of weaving in between it. It has an interstitial pattern, interstitial between the collagen bundles. And you can see it goes down relatively deep into the dermis. We're probably somewhere on the trunk here because of how thick the dermis is. Here's the other core, and you can see the same thing, or the other punch, excuse me, all the way down to the deep dermis. So let's go down and look closer at these. And believe it or not, these are actually vessels. Again, this lacks the big dilated vessels. Even at the top, the vessels are relatively small, but you can see they're well formed, and they're lined by a single layer of endothelial cells. Sorry, it's hard to get the light right and sometimes here. Here's your endothelial cells. And you might wonder, well, what are all these extra cells in the background? Well, I think you have a mixture here of compressed vascular channels. Like, see, look down here, you can barely, these are all vessels, but you can barely even see where the lumen of the vessel is. It's like probably right there, but it's really hard to see because they're so squished and compressed. But what you have here are endothelial cells that are pushed together with almost no lumen that's visible left. And then around them, again, you have a layer of pericytes. And there may be a few histiocytes or inflammatory cells here too. In cases like this where you can't tell the architecture and you're struggling, you can do a CD31, which is an endothelial marker, and also a smooth muscle actin, which will highlight the pericytes, and it will show you really nicely the outline of each vessel. So sometimes things that look cellular or like they don't have well-formed channels, when you do those two stains, it really highlights the organization of the vessel. See, again, here's a little lumen right there. Here's lumens right here. So again, we have compressed vessel. Oh, sorry, I guess those weren't on the screen. There's the lumens right here. And as you go down, it's the same thing. We've got all the way down to the dermis, these compressed vessels that are squished in between the collagen bundles, and they're weaving their way down in a non-destructive fashion, way down into the deep dermis here. So this is beautiful for microvenular hemangioma. And microvenular hemangiomas, again, they have a lot of similarity to the deep aspect of a Hobnail hemangioma, but the one difference is they don't usually have very much hemorrhage or hemosiderin, and so I think that that's one difference, is they lack that. And that's another thing that you'll usually see in Kaposi sarcoma, so that would kind of help you. And if you have any doubt, again, you can do an HHVA stain. And again, here's more of these compressed vascular channels in an interstitial pattern here between the collagen bundles. And here's yet another example. Shows very nicely. This one's not quite as cellular as the last one, but again, it's that same pattern where you can see the dermal collagen is intact and the vessels are compressed and in an interstitial pattern between each of these collagen bundles. And going to higher power here, these are much more obviously actually intact vessels with bland endothelial cells. And so this is called microvenular hemangioma. So the bottom aspect of a Hobnail hemangioma looks fairly similar, at least the vascular channel pattern looks similar to what we see here in microvenular hemangioma. Right, now there are a few other things that also can look like Hobnail hemangioma, particularly like the surface aspect of a Hobnail hemangioma. Here's one. And this is actually a lymph angioma, which is what we often call them, although in reality they're probably just lymphatic malformations. And this particular one actually is in the oral cavity, on the tongue. And you can see there are dilated, big dilated lymphatic channels up here. They look just like vascular channels really, but they tend to have this pink, frothy material in them. Maybe a little bit of blood sometimes can spill into them during processing, but this frothy stuff here that's pink, it's kind of hard to get to show up on the screen because it's so pale. That's a lymphatic fluid, it's lymph, okay? So when you see a lot of that in channels, here's some more of it in this channel right here, that goes oftentimes with a lymphatic phenotype. If you really want to know, you can do a podoplanin or D240 stain, and that will stain lymphatic endothelia and not vascular endothelia. Here's more of those dilated channels. So you can see, I think, right away that the dilated channels up at the top here in the superficial, I guess this is submucosa, but it's like the superficial dermis, that looks quite similar to what we saw at the surface of a Hobnail hemangioma. There's more of it there. But look, as we go down deeper, we don't get compression of the channels. We still have very big dilated spaces down here, okay? And so this goes along well with malformations, often go deep down into the dermis, even the subcutis or soft tissue, and have large dilated channels, sometimes with thick walls. I mean, this I think was in the tongue, and see here's skeletal muscle, the lesions involving the skeletal muscle here. It's got hemorrhage and hemosiderin. And look also, oftentimes, if you're lucky, in lymph angiomas, lymphatic malformations, you'll find actually lymphoid aggregates, and you can even find germinal center formation. You can see lymphocytes floating in the vascular channels, the lymphatic channels, excuse me. So this is a good finding for lymphatic malformation or lymph angioma. Now, they're not always so large and dramatic as this case here. Here's another example from the skin. And this, I think, is much more similar to what we saw actually in the Hobnail Hemangioma. It's dilated channels up at the very surface. As you go down, it actually looks like they might compress a little bit even. So you could think, oh, could this be a Hobnail Hemangioma? And they could have a few Hobnail cells. Again, hobnailing is kind of in the eye of the beholder. When you want to find it, you can probably find at least one cell that you say, oh, look, it's a Hobnail cell. This slide's kind of faded, and you may not be able to see it well on the video, but there's some pink frothy lymph fluid in here. And just because you see that doesn't mean that it couldn't be a Hobnail hemangioma. You can see that stuff in vascular non-lymphatic lesions also. And like I said earlier, some people think that at least some Hobnail hemangiomas may actually be traumatized lymph angiomas. So, but in this case, as you go down deeper, see, look, we're down deep, and we still have these big, dilated, ectatic lymphatic channels down here, down in the deeper tissue. So not as dramatic as that one in the tongue, but we're all the way down to the subcutis, and we still have dilated lymphatic spaces. Here's a big space right here, dilated kind of in between an erector pili muscle and a hair follicle. All right. So this is a lymph angioma again. And another thing that has a somewhat similar appearance to lymph angioma is this. This, you could say, well, that looks a lot like what you just showed. Dilated channels, they don't have much blood in them. But here, these channels are pushing up into the epidermis. Now, lymph angiomas can do this too. So the key is if you can see deeper down and see large channels like I just showed you, that would fit with a lymph angioma. But also, depending on the clinical appearance and the site, when you see big dilated vascular spaces pushing up into the epidermis so far that they're almost entrapped within the epidermis. See, this space right here is still lined by endothelial cells. And look, they kind of are hobnailed. See, you see why the hobnail term is not my favorite term? It's because it's so confusing, because everyone says, oh, well, there's hobnail cells, now what do I do? My main advice is don't get too freaked out about the hobnail cells. Start at low power and look at the architecture and decide what you think the lesion is. And then you can go and look at the cytologic features. The most important thing is making sure that you don't miss Kaposi sarcoma, angiosarcoma, something like that. And here, this is a really good example of actual, like, complete entrapment of those dilated channels up in the epidermis. Now, this was a dark red spot on the scrotum. So this is probably not a lymph angioma. This is probably an angiokeratoma. And there's different places and different types of angiokeratomas that you can get at different anatomic sites. But the scrotum is a good site for angiokeratomas, and they're sometimes multiple. And they can sometimes, when they're multiple, go along with different syndromes. And that's a topic for a different video. But angiokeratoma, when you see dilated vascular channels that are really thin-walled and they're completely entrapped up in the epidermis, think of angiokeratoma. And like I said, I think lymph angioma and angiokeratoma can look quite similar, especially when there's not much blood. Here's another, sorry, the slide's a little dirty there. Here's another example of angiokeratoma. This one has more blood in the spaces, and you can see again how the epidermis is kind of reaching down here to completely entrap this superficial aspect. So if you said, well, how would I tell this apart from Hobnail Hemangioma? If you started showing me little channels trickling down in hemosiderin, I would call it a Hobnail Hemangioma instead of an angiokeratoma. Again, also I take into account kind of the clinical and the site. If they have multiple red papules on the scrotum or something like that, I would say, oh, well, maybe it's more likely an angiokeratoma. And again, both lesions are benign. And sometimes angiokeratomas actually can have so much blood that they can really be hemorrhagic. They can begin to break down, and the surface of the lesion can either get necrotic or ulcerated. Like here you can see this is epidermis up here, but it's all dead. So this is probably irritated or traumatized or thrombosed or a mixture of those, and the epidermis is starting to die, and the blood is filling up and making thrombus. Actually, you can see fibrin in here. It's a little hard on the video to pick out, but the bright pink stuff right there in the middle is fibrin, and it's starting to make an organizing thrombus here in the middle. And so these lesions, when they get like this, they can look black and kind of crusted and irritated. Clinically can look very worrisome for melanoma. So I find that vascular lesions that get traumatized and thrombosed and that begin to have necrosis of the epidermis over them oftentimes will look very worrisome clinically. All right, so those are all angiokeratomas. And the one last thing that I would bring up that can kind of look like angiokeratoma, look like lymph angioma, or like Hobnail Hemangioma is this lesion right here. You could say, well, that looks just like what I've been showing you. Dilated channels, they're filled with lymphatic type fluid, but they're entrapped in the epidermis. So you could say it could be an angiokeratoma, could be a lymph angioma. There's some inflammation down here. Look at this dermis. This dermis is very sclerotic, very dense collagen. And we've got a lot of vascular channels as we look around that are very dilated and ectatic, kind of everywhere. And it turns out that this is from a radiation site. The person had breast cancer and it was radiated, and then this flesh-colored papule popped up in the middle of the radiation a few years later. Any lesion arising in a radiation site, you always have to think about angiosarcoma, because post-radiation angiosarcoma, even though it's rare, it certainly happens, and it happens, I mean, on a regular basis. It's just so many people get radiation. The risk relatively is small, but definitely I've seen many cases of it. And so usually post-radiation angiosarcomas are going to be bruise-like, they're going to be large and spreading, and but these lesions usually are small papules, and so this is called an atypical vascular lesion, which I don't really love that name, to be quite honest, because these usually don't have atypia, not in the traditional sense. They look a lot like a lymph angioma or a Hobnail Hemangioma or a angiokeratoma, but they're arising in an irradiated site. And if you want to learn more about this, go and check out my vascular tumor video that I referred to earlier. I talk about AVL and how to make that diagnosis and tell it apart from angiosarcoma. But I just wanted to bring up, I've definitely seen an AVL that at first glance I said, oh, it's going to be a Hobnail Hemangioma. And then I found out that it was in the site of radiation on the breast. So much more likely, I think, in that case to be AVL. And there's some different things that go along with that you should know about. And you can watch that video to see. All right, now finally, we're going to talk about one other entity. When we talk about hobnail things, this entity needs to be brought up. It's very rare. Oh, let's turn it around. Here at the surface, we have dilated channels, and I apologize, this slide is relatively old and faded, but I still think it's probably the best example in my collection. So we've got dilated channels up here. When we go closer, now no one can argue about this. These are hobnailed cells. Look at those guys. These round cells that bulge into the lumen. They have very little cytoplasm. They kind of, again, look like they're like nuclei that are almost naked, just kind of pushing up into the lumen of the vessel. And you can see all around, look at these channels they're a single layer. They don't have pleomorphism, or really, they might be a little hyperchromatic, but they're not pleomorphic, and they're one layer. Unlike, say, angiosarcoma, which often gets pleomorphism and often gets multi-layering. But they're definitely hobnailed, and we've got these big dilated channels here. And now the other key, though, is as we go down deeper, this is not a small lesion like I've been showing you. This is a big lesion. And look, it goes deep, deep, deep down. Way down into the deep dermis, the subcutis. And you can see areas like this, I think, show really well. The vascular channels branch and kind of make these kind of cleft-like arborizing branches that really in many cases resemble what you see in the reedy testes, a normal structure in the testis. And so this is referred to as a Retiform Hemangioendothelioma. And hemangioendothelioma is, there's a handful of different types of hemangioendotheliomas. Again, I talk about that in my vascular tumors video. They're not just different variations of the same thing. They're all unique and independent from one another for the most part. But they're basically vascular tumors that of intermediate behavior. They're not fully malignant, but they do behave in a more aggressive fashion than a regular benign vascular tumor would. And so these tend to occur on the distal extremities, particularly the foot. I've also seen them on the hand, and they have a pretty strong tendency for local recurrence. Over half of the cases will recur locally, but only rarely will they metastasize. And to my knowledge, there's not been any fatality associated with this tumor yet, at least at the last time that I looked. And again, the channels are very dilated and branching, and they're all lined by these hobnailed cells without atypia. And again, this is the area really kind of, if you go look up a picture of reedy testes, it looks quite a bit like this, I think. Now, a genitourinary pathologist might hear this and say, that's terrible, it doesn't look anything like it. So sometimes in pathology we make comparisons, and not all of us agree that those comparisons look the same. So anyway, and you can see it just keeps going. It's very infiltrative, and that kind of explains why I think if you don't really get around this completely with a wide excision, it's going to come back, because it's infiltrating all the tissue around it. So it's a very infiltrative, kind of a locally aggressive process. But we don't call it a malignancy in the traditional sense, because the chance of it metastasizing or causing death is extremely low. So again, this is a nice example of Retiform Hemangioendothelioma. And the reason I show this here in this video is that some people have used the term Hobnail Hemangioendothelioma to encompass this lesion, Retiform Hemangioendothelioma, and also maybe to include another lesion called the Dabska tumor, or papillary intralymphatic angioendothelioma, which is a long name, that's why we call it Dabska tumor, which is an even more exquisitely rare tumor that also has hobnailed cells, but has these kind of papillary tufts in the vessel, and that's a topic for another video or another day. But here's a nice Retiform Hemangioendothelioma, and it's good to remember that these are another entity that have really prominent hobnailing of the cells. But it's real important that you don't mistake Hobnail Hemangioma for one of these hemangioendotheliomas. And the big key is that all those lesions I showed you earlier of Hobnail Hemangioma, they're small. They're small skin lesions that maybe go into the mid-dermis. And here, even on 2x magnification, I mean, look at this thing. It's huge. And it goes way, 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 way down, all the way to the base, way down into the deep soft tissue. All right, one more. And this one is a little smaller. So here, this is also a Retiform Hemangioendothelioma. You may say, well, this doesn't look very much like that last case. Here, this is on the distal extremity again. In the acral site, you can see we have acral skin on the surface. Sorry. Got a Pacini's corpuscle down here, a nice beautiful onion skinning. This is probably my favorite histologic structure in the whole human body. I think they're really beautiful to look at. Deep pressure vibration sensors. But up here we've got dilated channels with hobnailed endothelial cells. So you could be thinking about a Hobnail Hemangioma. But there's some differences here, that in the background we have real dense sclerosis. Dense collagen without many fibroblasts. That's what we call sclerosis. Dense collagen without much in the way of fibroblastic proliferation. And look, as we go out to the sides here, these aren't those compressed channels that I showed you in a Hobnail Hemangioma. These are compressed, but they all have like plump, kind of hobnailed-like cells in them. And you can see it really has a very infiltrative look deep down into the tissue, still with these very hobnailed cells. So because of that, I think this is what makes this lesion, that and the sclerosis and this infiltrative growth of channels lined by hobnailed cells, not little compressed thin endothelial cells, but these hobnailed cells. That's what makes this a Retiform Hemangioendothelioma. Because of that. And again, these are locally aggressive. See, look, it's growing all the way down here into the area down in the, I guess is the deep subcutis, or I'm sorry, not the deep subcutis, the deep dermis, almost to the subcutis. In the hands and feet, all of the different planes of tissue are very close together. I think I've got another section of it over here. And yeah, again, you can see the very nice hobnailing. Beautiful example, kind of matchstick looking nuclei pushing into the lumen. And again, the channels are very infiltrative and still even down deep lined by Hobnail cells. So I think the main concern I had when I first saw this case actually was not for Hobnail Hemangioma, but I wanted to make sure I wasn't missing a subtle, well-differentiated angiosarcoma. But this case didn't have any mitotic activity, no atypia. The channels had this branching architecture, and they were lined by the Hobnailed cells, but they didn't have any atypical features. And actually, I was not the only person to look at this. Another expert also saw this and agreed that this was a Retiform Hemangioendothelioma. So again, locally aggressive, often recur locally, but the chance of metastasis is very low, and to my knowledge, not fatal in any case yet. So hopefully this helps you at least get a little bit better understanding of a few of these unusual vascular entities that can look like one another. And thank you for watching. Please click like and subscribe to my channel if you want to be informed about new videos that come out. And leave comments or questions down below, and I'll do my best to either address them in a future video or answer them.